Yeah, so I'll be starting my topic. My topic today is radiotherapy techniques and timing. Before that, I would like to thank the chairperson, the organizers, and especially Dr. B.K. Smriti and Dr. Kumar Prabhash for inviting me and giving me this platform. So, since my topic is radiotherapy techniques and timing, I will not get into the details of evidence because my time is around 15 minutes and I will have to finish my talk within that time. So, we all know that lung cancer is the brain metastasis in lung cancer is common, and Scouten et al. Has reported that among all cancers, brain metastasis in lung cancer is to the tune of around 15 to 16%. The National Cancer Database of non-small cell lung cancer of more than 4 lakh patients said that around 10% of the patients reported brain metastasis, which is in almost around 50,000 patients. And also the SEER database between 2010 and 2016 reported brain metastasis in almost 15.5% patient in a cohort of small cell lung cancer. And I think that is a very high percentage. All brain metastases are not same. We have to pick and choose our brain metastasis and decide how we want to treat them with palliative intent, with aggression, and RPA, recursive partition analysis. These are the classes, class 1, class 2, and class 3, which has been described here. And we can see that the median survival differs in different different RPA classes. So we have to select and choose our patients accordingly. Talking about the management, traditionally, brain has been, there has been a talk about sanctuary sites. Traditionally, brain had been considered a sanctuary site, and radiation has been widely used and been effective in treatment of metastasis from lung cancer. And of course, the initial thesis was seed and soil hypothesis, for which the whole brain radiation treatment had started. Of course, we have moved on from there, and we have various other techniques and treatment. Today, we will be, since technique is one of my topics, I'll be talking about role of PCI in small cell and non-small cell. I'll just touch upon them because I know there's a detailed talk on small cell lung cancer. I'll be talking about the techniques of whole brain radiotherapy, WBRT with hippocampal avoidance, stereotactic radiosurgery, and post-op surgical cavity boost with SRS. And of course, I will be talking about the optimal timing wherever it is possible. So, role of PCI in small cell lung cancer, as we all know, small cell lung cancer is highly chemosensitive, but chemotherapy, the traditional belief is, does not readily cross the blood-brain barrier, and the intracranial failure rates remain very high. And due to innate radiosensitivity of small cell lung cancer, low-dose cranial treatment would or had reduced the chances of development of brain metastasis. So this is a meta-analysis of 9 trials, total 9, almost 1,000 patients, and this was a meta-analysis of patients who had complete remission. The main endpoint was survival, and as we can see, the mean reduction of the risk of death was much higher in the group which received PCI, and there was absolute increase in survival of almost 5.4%, and mean reduction of risk of brain metastasis, there was an absolute decrease in 1 in 4 patients to a tune of almost 25%. So, as we have said, absolute benefit, overall survival is 5%, disease-free survival is 8.8%. So, was it only complete responders in whom we could do PCI? This is Ben Slotman's trial, which saw patients with partial or complete response to chemotherapy in extensive small cell lung cancer as compared to the limited stage in the earlier meta-analysis. And here also, after PCI at 5 to 6 weeks, survival without disease progression was significantly longer in this group, significantly longer overall survival. The cumulative risk of symptomatic brain metastasis were lesser in the group which received PCI, and the side effects of radiation, it did not impact the global health status. So, timing of PCI varied. Literature does not really write about the ideal time about PCI, However, in a concurrent chemoradiation setting, after completion of CTRT, the optimal interval is not defined, but it is recommended to start soon after the resolution of acute toxicities of initial therapy. And in a sequential CTRT, which is less practiced these days, PCI is delivered after the chemotherapy is over and often simultaneously with the radiation therapy. Dose escalation, the current standard dose recommended by various institutions is to the tune of 25 gray in 10 fractions. RTOG 0212 tried to escalate dose. Some studies has escalated dose just to the tune of 36 gray, but the neurocognitive effects have diminished in the dose escalated arm, and dose escalation is really not recommended in small cell lung cancer. Role of PCI in non-small cell lung cancer, I'll just skip through these slides, but the gist of the whole story is RTOG 0214 did a randomized control trial. It prolonged the disease-free survival, but in none of the studies, overall survival has improved. So it has still not become a standard of care. And most of the studies which saw benefit was in stage 3 and not in all comers. So most of the standard of care still does not recommend routine role of prophylactic cranial irradiation in non-small cell lung cancer. Talking about hippocampus avoidance whole brain radiotherapy, we'll just run through the evidence once. Hippocampus avoidance whole brain radiotherapy is a technique of whole brain radiation where you avoid the hippocampus for neurocognitive function. I put these slides here because we talked about neurocognition, and the ASCO SNO Astro guideline clearly states that Mementin and hippocampus avoidance should be offered to patients who will receive whole brain radiation, no hippocampal lesion, and 4 months or more survival. Neuroprotectors, there have been various trials, NRG CC001 and a single arm phase 2 RTOG 0933. Mementin has shown to have excellent impact, or Mementin combined with hippocampal avoidance has shown to have excellent impact on memory and cognition. However, other agents like donepezil or motaxafin really has not shown that benefit which Mementin has shown. Talking about the techniques, because techniques is one of the topics, we all know radiation started with whole brain radiation. It was a seed and soil hypothesis. Whole brain radiation is easy to plan. It is delivered usually over 5 or 10 fraction. Planning is simple. You can also do a 2D planning. Parallel opposed fields have been commonly used, but the limitation of whole brain radiation have been neurocognitive decline, brain edema, and inability to escalate doses. So when you had multiple metastasis and you need to plan whole brain radiation, as we have already talked, you can, for neurocognitive and sparing of memory, you can avoid the hippocampus. Contouring of hippocampus is a different topic altogether, but you can do hippocampal avoidance and you can deliver dose constraint to the hippocampus by sparing hippocampus. You will have a lesser decline in memory, and this is how it really looks on a radiation map. The hippocampus sparing, or HA, hippocampal avoidance whole brain radiotherapy. After whole brain radiotherapy, the era with the development of immunotherapy, better drugs, limited brain metastasis, better brain control, the era of stereotactic radiosurgery took place. Stereotactic radiosurgery started with Lars Lexell with a fixed frame 3D concept, where there was a concept of target localization, and after localization through imaging, you delivered after localizing and contouring of that region, you delivered a very high dose of radiation in single fraction, and that's why the term surgery came in. And then, of course, the concept of stereotactic radiosurgery and the definition was expanded to up to 5 fractions. This is from frame-based, we moved on to frameless, where you are using relocatable mass so that you can do in more than 1 fraction. This is just an image, and this is how typically the dose map looks about. Toxicities of whole brain radiation, neurocognitive decline, you can see the percentage is very high, nausea, vomiting, fatigue, skin toxicities, headache. And in SRS, it's radionecrosis, edema, headache, hemorrhage, and motor deficits are to a tune of much lesser extent. Timing and sequencing of therapies. Since evidences are so many, I thought I will present the gist of evidences and talk about the ASCO, SNO, ASTRO guideline, which all of us who are practicing oncologists, it's a pretty robust guideline published recently, and all the students and practicing oncologists should have an idea about it. So surgery, Dr. Prakash has had a beautiful talk. Just to summarize, surgery may be offered to patients with brain metastasis for the diagnosis of primary cancer, for patients with large tumor and mass effect, and patients who have multiple brain metastasis and uncontrolled systemic disease are less likely to benefit from surgery. One question which often comes in our clinical practice, what do we do with patients with poor performance status? Do we do radiation? Are there any guidelines around it? The guideline around it is if the KPS is less than 50 or if the KPS is less than 70 and there is no systemic therapy available, although the evidence quality is low, whole brain radiation therapy may be avoided, and best supportive or optimal supportive care. There is a course trial which has shown that optimal supportive care with corticosteroids has equivalent outcome to whole brain radiotherapy. In that subset, whole brain radiotherapy may be omitted. 1 to 4 brain metastasis. Here you will get all types of evidence. Whole brain alone, whole brain followed by SRS, surgery followed by whole brain, surgery followed by SRS, SRS alone, surgery alone. But, all of it is valid, but the world is moving more towards SRS alone or surgery followed by SRS in patients who have mass effect and symptomatic. There is enough evidence to that. And the world is moving away in a limited brain metastasis where systemic disease is controlled. The world is moving away from whole brain radiation, and the guidelines which have come over the last 5 to 6 years, they talk about SRS alone. And if there is a recurrence, we treat the patient with SRS or consider whole brain radiotherapy in those occasions. This is a matter of debate in all our conferences, but let us accept the fact that there is overall survival data is now tilting towards SRS as compared to whole brain radiotherapy in oligometastatic, limited metastasis, and where primary disease is well controlled. SRS adjuvant to surgery. SRS alone can be offered to patients with 1 or 2 resected brain metastasis if surgical cavity is safely treated. There is enough evidence on that now. So evidence quality is intermediate and strength of recommendation is moderate now. So that is what we call, that is my next technique, which we call as cavity boost. So you radiate the cavity, and there are meta-analysis which has shown that cavity boost as compared to surgery alone has shown local control to the tune of almost 83%, 1 year local control, and radio necrosis rate to a tune of almost 7%, which is quite reasonable. What about multiple brain metastasis? It is more than 4 unresected or more than 2 resected brain metastasis. If it is more than 4 unresected metastasis, whole brain radiation should definitely come in as a palliative modality there. Whether to add SRS to whole brain radiation is a matter of tumor board decision or a choice which a doctor needs to make with the patient. Now talking about patients with asymptomatic brain metastasis, because this is a situation we often come across in our clinic. Should we start radiation immediately? So the recommendation 2.2 in this guideline says local therapy should not be deferred unless it is specifically recommended from recommendation 2.3 through 2.7, which I will be talking about, and the evidence quality here is quite high. So what is those recommendation 2.3 to 2.7? Osimertinib or icotinib may be offered to patients with asymptomatic brain metastasis from EGFR mutant NSCLC. And if these agents are being used, you can defer your radiation therapy. So timing does not have to be immediate. Timing can be delayed. Similarly, alectinib, brigatinib, or ceritinib may be offered to patients with asymptomatic brain metastasis with ALK-rearranged NSCLC. And if these agents are used, local therapy may be delayed unless there is evidence of intracranial progression. Pembrolizumab has also found its place in programmed death ligand PD-L1 NSCLC who are receiving pemetrexed and a platinum agent, although the evidence quality is low here. For patients who are receiving radiation therapy and surgery both, there is no specific guideline on sequencing of therapy or timing may be made. There is not enough literature. So, to summarize, treatment of brain metastasis has evolved over the last few years. We are done away from only whole brain radiotherapy era. However, whole brain radiotherapy still is a very important treatment modality, and it should be used to palliate, improve quality of life, and in the setting of multiple brain metastasis. Combination therapy of whole brain with stereotaxy, surgery with stereotactic radiosurgery, surgery followed by whole brain radiotherapy are a multimodality tumor board discussions. Deference of radiation in view of an agent in asymptomatic brain metastasis is an option in to preserve the neurocognition, and radiation in those cases may be preserved for when patient progresses or becomes symptomatic. Thank you for a patient hearing. Thank you.